Professor Magdy Elsharkawy, he was presented earlier as well. He's graduate from Ain Shams University, and currently he's a professor and director of renal transplant program in Ain Shams University in Egypt. And he is a member of the editorial board of Journal of the Egyptian Society of Nephrology and Transplantation. And he's the organizer, he's from the organizer committee of the Egyptian Annual Dialysis Conference, and he is going to speak today about prevention and reversal of CKD. Are we there yet? Welcome, Dr. Magdy again.
Thank you very much. I'm happy to be here again. My presentation now is different than in the morning. It's about CKD, BKD, which are not so different now. Maybe they are almost the same, except if you are diabetic kidney disease, you take treatment for diabetes. But the management will be united very soon. So what happens in nephrology is that we don't have MACE like in cardiology. They have major adverse cardiovascular event. We don't use this term yet. And we have to have some acceptable outcomes. And we need to change our current management to future management. So this is a very interesting paper saying that, yes, we might have a major adverse renal event. It may be 3, 4, or 5. First, the incident CKD, the progression, the proteinuria, the GFR, and the renal and cardiovascular death, because they are inseparable. You can, as mentioned immediately before me, Professor Muhammad, we cannot separate CKD and heart disease. So we may use the endpoint or surrogate markers to determine are we on the right way or not. Mainly the GFR and the albuminuria together with renal and cardiac endpoint. This is our endpoints that are very important, and we know that cardiovascular death as well as the progression to end-stage kidney disease is dependent on the albuminuria as well as the GFR. And cardiovascular outcome is dependent on the GFR. And wherever you have low GFR, the cardiovascular outcome is worse. So this is the two important things. So when the study started to prevent or treat or hold the progression of end-stage disease, the first study was the UKPDS, one of the major landmark studies in diabetes, where they were using insulin, the NPH and crystalline insulin and sulfonylurea only, and good antihypertensive medication. They compared strict glycemic control, strict blood pressure control versus what was there in 1977, the traditional treatment. And the result was astonishing. 37% reduction in progression to end-stage kidney disease. This just by adjusting diabetes. And 44 years later, this is a fourth time reading this study because people are still alive. The numbers are less, but 300 patients are still alive of this study. And they find there is still benefit of tight glycemic control and good antihypertensive control. This was confirmed 40 years later by this very interesting study. 35,000 patients followed up for 15 years. And it was shown that as high as A1C, more than 6.5, for more than 1 year, there is progression to end-stage kidney disease. Second important issue is blood pressure. We need to control blood pressure. We need to keep the patient blood pressure is below 140/90. Because above that, he will lose 10 years out of his life without end-stage kidney disease versus when you control his blood pressure. This was a very elemental thing. And this is a KDIGO hypertension guideline that contradicts the American Society of Cardiology and the European Society of Cardiology, that the target blood pressure is 120, the systolic 120. Other guideline is 140 for chronic kidney disease patient. Then the story of RAS. We heard a minute ago that Professor Muhammad doesn't like RAS blockade. But in nephrology, it's actually started with RAS blockade. In 1993, a very interesting publication of a study that lasted 4 years by Lewis, showing that using captopril, which is not used anymore, have resulted in 50% reduction of progression to end-stage kidney disease and reduction of proteinuria. This was followed by the micro-hope, ramipril, again, 23% reduction of progression to end-stage kidney disease. The renal with losartan, the ident with irbesartan, they all confirmed that RAS blockade in diabetic kidney disease as well as non-diabetic kidney disease, there is very good reduction of proteinuria and the progression. And the meta-analysis of all this study showing benefit of using RAS blockade in such patients. However, there were a lot of residual risk. And one other important aspect, there were no reduction of mortality in our patient. Progression was reduced, proteinuria was reduced, but they die at the same level like non-diabetic, patient not using RAS blockade. So with RAS, yes, we have achieved something, but not yet. And we had to wait 25 years later for the first medication ever after RAS that shows benefit for kidney disease as well as heart disease, the SGLT inhibitor, 2 inhibitor. They were started by the EMPA-REG study, followed by the DECLARE study, the CREDENCE study, and then they further studied with DAPA-CKD, dedicated for kidney, EMPA-Kidney, dedicated for kidney, and also they tried it in non-diabetic patients because this medication started as an anti-diabetic medication. Nowadays, they are not anti-diabetic medication. And they have changed the level of the study. In the DECLARE, the patient have mild renal impairment and mild proteinuria. In DAPA-CKD, CREDENCE, and EMPA-Kidney, they have patients with GFR 20 and proteinuria more than 5 grams. So they studied all category of kidney disease. And astonishingly, this is a CREDENCE study showing that there is leveling of serum creatinine using this medication versus not using them. And the projected effect on GFR have extended the life of the kidney, not needing dialysis by 15 years. So when you have a patient who started treatment with GFR 50 versus non-using this medication, he will have 15 years away of dialysis. This is a very astonishing result. Again, this is a meta-analysis published last year in November, showing that in all the studies, the CREDENCE, in EMPA-Kidney, the DAPA-CKD, there is beneficial effect of using this medication to hold the progression of chronic kidney disease and to stop proteinuria. And even in non-proteinuric patients, we will hear from Professor Iman about IgA nephropathy. This is an IgA nephropathy, non-diabetic patient, also this very successful. And in the KDIGO guideline 2022, published last year, there is not just reduction of proteinuria GFR, but the major adverse cardiovascular event was reduced. So survival, here is the survival benefit, not just kidney benefit. Adding to them GLP-1. GLP-1 is very important for the heart, and also it reduces proteinuria and major renal endpoint, except maybe lixisenatide. All of them are beneficial for the kidney. So we have now medications to prevent or to hold the progression. Even tirzepatide, the GLP-GIP combination, which we are using for what? For obesity. It's very, the Mounjaro, you know the Mounjaro? Of course. Everyone now is asking for it. I don't know if it is present in Oman or not. It has a very good effect in reduction of proteinuria as well as keeping GFR stable with reduction of cardiovascular mortality. So this medication by sodium glucose transport inhibitor, GLP and GIP, we are not here yet, but we are getting closer to the target to prevent or even to cure chronic kidney disease or diabetic kidney disease. Then 5 years later, we have the MRAs, the non-steroidal MRAs, the finerenone. dihydropyridine, acting on inflammation as well as on the kidney itself. And the Fidelio and the Figaro study showing further 23% reduction in proteinuria and cardiovascular risk factor for this patient. And this is a very, very recent study showing that as early as first 4 weeks and as late as 4 months, finerenone protect against cardiovascular event and kidney disease progression in patients with type 2 diabetes. It is not yet approved for non-diabetic CKD, but it will soon. And even spironolactone and eplerenone have the same effect. Using this medication have resulted in preserving the kidney function with very important side effect, hyperkalemia. So we should keep an eye on hyperkalemia in such patients. What about adding them together? Now we have 3 medications that have proven effect on kidney disease, RAS, sodium glucose transport inhibitor, and MRI. And there are very interesting studies. This is dapagliflozin with eplerenone showing further reduction in proteinuria. And many patients achieved more than 30% reduction and 50% reduction of proteinuria using eplerenone with dapagliflozin. So again, a step forward into prevention of chronic kidney disease. Another animal study in empagliflozin and finerenone showing that in those animals who used the full dose of finerenone and empagliflozin, this is the first, when you see this purple line, as if they don't have any kidney disease. And these are an animal study, not yet approved in human, but there is a coming study, the confidence study. It is designed, it will be published maybe in the end of next year, using finerenone and empagliflozin in human. This is a huge study ongoing now, and we are waiting for the result. So combining these medications together, we may reshape the future of chronic kidney disease. We are very close now. We have a lot of improvement. This is the KDIGO guideline 2023, published 2 months ago. This is just a draft. And for the first time, we have a drug that have 1A evidence. They recommend treating patients with type 2 diabetes, chronic kidney disease, GFR above 20, with sodium glucose transport inhibitor. And if the patient have heart failure with GFR more than 20 and proteinuria more than 200, you have to use sodium glucose transport inhibitor. And this is class 1A. And what I don't show you is that you don't check for GFR after using sodium glucose whatsoever. This is the guideline, but it is 2A. So when you start, not like cardiologists, we don't check for GFR anymore. It's not recommended because it will not affect the outcome. The GFR will dip, but it will not affect the outcome. So we don't check for it. And also the second important guideline, which is 2A, we suggest a non-steroidal MRA for adults with type 2 diabetes and GFR above 25, but with normal potassium and if proteinuria is above 30. Second is a non-steroidal MRA may be added to RAS and sodium glucose for treatment of type 2 diabetes and CKD in adults. This is not graded yet, but maybe in the future, after the confidence study, we'll use them together. And this is a guideline that have changed this year, the ADA 2023, sodium glucose GLP-1 for type 2 diabetes, and they recommend using it with GFR 20, and GFR, if it is normal with proteinuria, you use it. The 2023 American Association of Clinical Endocrinologists, the same, use it for CKD patient, as well as, of course, heart failure. And this is a very interesting graph showing that using RAS in patient with GFR 60, you will extend his kidney life by 10 years. Adding sodium glucose transport inhibitors, you will add another 15 years. So together, patient will be away of dialysis for 25 years. What about inflammation? This is my last few slides. Are we going to treat inflammation because we know that inflammatory pathways are very important and we may target inflammation. This is a very interesting publication showing that maybe if we target inflammation in diabetic kidney disease, we will achieve 2030 outcome. And they have said clearly there is many aspects of inflammation causing diabetic kidney disease and chronic kidney disease. We have inflammatory markers, TNF-alpha, TLR2, NF-kappa beta, we have CCL2, interleukin-6. We have a lot that we can target, and actually there are medication used by rheumatologists for this inflammatory markers. So medications are present, and there are a lot of trials. But if you look closely, you cannot read this slide, I know. All these studies have targeting anti-inflammatory pathways and cytokines. And all these studies were active until 2016. And in 2020, all of them has been stopped. Why they have stopped? The explanation of the writer is that although there is growing interest in inflammation in diabetic kidney disease, and there is a lot of randomized control trial, but the outcome is not satisfactory. And the same for antifibrotic drugs. And why is that? Because the success of randomized trial in sodium glucose transporter inhibitor and phenylenone with a good outcome and also anti-inflammatory effect. You will find that when you target metabolic target by using GLP-1 and sodium glucose, there is effect on inflammation. And there is preclinical and the clinical outcome, not like targeting the inflammatory marker. And also, by using RAS blockade, you are also targeting the inflammation with good hard outcome. But the other arm targeting inflammatory marker have no clinical outcome up till now. So, sodium glucose transport inhibitor, we have evidence for using them. Phenylenone, we have evidence of using them. And this is a very interesting graph, exactly like what Professor Muhammad showed. When you have a diabetic patient, you should use sodium glucose from the start. Don't hesitate. If it's not diabetic but has cardiovascular risk, you have to use them from the start. What if the patient have non-diabetic kidney disease, but he has a glomerulonephritis? So you have to separate the patient. If the glomerular disease can be treated by, if it is primary, okay, we'll try immunosuppression. If secondary, immediately put him on sodium glucose transport inhibitor. So if you try immunosuppression with no response or you need a prompt remission, use sodium glucose. And if you started immunosuppression and you get remission, it's okay. Incomplete remission, you have to use sodium glucose transport inhibitor. And this is a very good slide, and I think the future will be reshaped after this all medication in hand. And thank you very much.
Thank you.